Greetings from New York City. My name is Dr. Scott Kellogg. I'm a schema therapist and I'm a chairwork psychotherapist. And today I'm going to be speaking about how we can integrate these two forms of psychotherapy and these two forms of healing. So foundations, and here I'm going to start with chairwork psychotherapy first. My understanding of chairwork psychotherapy is based on the four orienting principles. And the first of these is multiplicity of self, which is the idea that it's clinically useful to understand people as containing different parts, mode, voices, or selves. And as many of you know, multiplicity of self is, taking over the whole world of psychotherapy. And certainly in schema therapy, the mode model is definitely a model of parts and multiplicity of self. So not only is it useful to understand people in terms of their parts, but it's healing and transformative for people to give voice to these different parts. It's also healing and transformative for people to enact or reenact scenes from the past, the present, or the future. And this connects us to the psychodramatic origins of chairwork. I would say the ultimate goal of chairwork, and really the ultimate goal of all of psychotherapy, is the strengthening of the ego, as Freud put it, the healthy adult mode, as we say in schema therapy, or the inner leader, as we say in chairwork psychotherapy. This is the true north of the work. Whenever we're lost, we're confused, we're not sure what to do. Where is the healthy adult mode? Where is the inner leader? Let's get our patients there. Because ultimately, the stronger the healthy adult mode, the greater the internal self-regulation, emotional self-regulation, and the better the functioning in the world. Just to be clear, when I say the word inner leader and I say the word healthy adult mode, these are the same things. They're just different words from different disciplines for the same phenomenon. A little history and background. Many of you know Dr. Jacob Moreno is the creator of psychodrama, and it's Dr. Moreno who created chairwork. But chairwork, as we come to know it, is really the work of Frederick or Fritz Perls, the creator of Gestalt therapy. From the early 1950s to the early 1960s, Perls was a regular attendee at Moreno's open psychodrama sessions in New York City. So it's here that Perls learns chairwork from Moreno. But at least in my opinion, Perls takes chairwork beyond what Moreno had envisioned and really turns it into what I would call the psychotherapeutic art form. He also moves it from the group setting to the individual psychotherapy setting, which makes what we're talking about today possible. I first discovered chairwork in 2001. I was working as a schema therapist in Jeffrey Young's Center in New York City. But when I discovered chairwork, I fell in love with it. And essentially, I went on a journey first to really deeply understand chairwork. And I'm still on that journey. But after I began to understand chairwork better, I then began to work to integrate what I'd learned into schema therapy. And so this talk today is really the story of where I am in that journey. So the four dialogues. So as I said, I first discovered chairwork in 2001. But in 2018, I had a kind of revelation in which I realized that all of chairwork, all these things that we do with the chairs, can really be understood as being based on four core stances. So to learn to do chairwork psychotherapy, you don't need to learn 10,000 things. You, in fact, only need to learn four things. And this was an astonishing discovery for me. It changed my practice. It changed the way I train people in chairwork. And I see it really as a crystallization of really 60 or 65 years of chairwork development and chairwork exploration by many therapists. First of these is giving voice. So here you might say to a patient, I'd like to invite you to move to this chair. And I would like you to speak from your heart and speak from your pain. So I consider this when a patient says, there is a deep grief within me. Can you go to this chair? Can you go into your grief? Can you experience it? I feel this pain in my heart. I feel this pain in my back. I just feel so sad. I can't believe she's gone or whatever that experience, but just go into it as deeply as you can. Or you might consider when a patient says, there's a part of me that wants to cut myself as soon as I leave the session. Can you go to this chair? Can I talk to this part? Can I better understand this part? And this especially you'll see us doing this a bit later in the talk. This connects us to Gestalt therapy and to voice dialogue. So giving voice allows us to amplify and give expression to a feeling. I also like to locate specific feelings in specific chairs as specific parts. So there's an angry part, there's a sad part, there's a frightened part. And also we can use this to interview a part to better understand it, to understand this part that wants to cut themselves or do something else. Second one are internal dialogues. So if giving voice involves one part, internal dialogues usually involves two parts and sometimes three. Might say to a patient, you seem to be of two minds about the project. I wonder if you're willing to go to this chair and speak for the part that wants to go forward with it, and then to this chair and speak for the part that's having second thoughts. So I consider this when a patient says, I'm conflicted about this situation. There are different kinds of conflicts, but one is there's a value conflict between two things that are important, work, family, things like that. Or I have a deep fear of elevators. I'm afraid I'll be trapped in one and die there. So this is more the idea of a cognitive distortion in one chair and a rational response in another chair. This would be kind of your cognitive restructuring dialogue of challenging a problematic belief or schema. I have this voice in my head that keeps telling me how bad I am, right? Inner critic, healthy adult mode, some sort of restructuring, rebalancing the forces within the self. And we'll talk about that later as well. So typically these take the two forms. One is polarity dialogues and the other are mode dialogues. Storytelling. Roberts and Holmes wrote, at the heart of any therapeutic encounter, there is always a story. So you might say to a patient, I sense that holding the secret inside for so long has been a terrible burden. If you're willing, I'd like you to move to this chair and tell me the story of what happened. Again, we always get people to move to another chair to do these things. But this storytelling, this is really the heart of so much of psychotherapy. This is the sacred space of therapy, where people come, they tell their secrets, they tell the stories, they share what has been unshareable for them. This is one of those profound things we do as therapists. And relationships and encounters. I might say to a patient, I sense that you're still very stuck, even though the relationship ended 2 years ago. I'd like to work with that, if I may. I'd like you to imagine her sitting in this chair. I'd like you to talk to her and tell her what you're feeling. So we might consider this when a patient says, I know it's been 3 years, but I'm still grieving the death of my mother. In the world of grief therapy, chairwork is a standard technique. One of the most powerful things we can do with people that we've lost. But my father was very cruel to all of us when I was growing up. I'm still very angry about that. Mistreatment, abuse of some kind. Here we do what we call confrontation dialogues. And you'll see that later. We talk to people who hurt us, betrayed us, mistreated us. Or my sister's just impossible. I feel responsible for her, but she's driving me crazy. Difficult relationships, not people who are abusive, but people who are problematic. Their behavior is problematic. It's another kind of dialogue. And deepening techniques. The central goal in the chair work, where you're doing chair work, is for the patient to be able to express each voice as distinctly, forcefully, and simply as possible. We're trying to get patients into high levels of affect. Right? That's one of the healing mechanisms of chair work. There are many ways to do this, but just to mention one at the moment is existential language. We really want people to say things like, I want, I am deciding to, I am choosing to, I will or I will not do something. This is the language of the healthy adult mode. We do not want them saying things like, I must, I should, I need to, or I can't. This is language that takes away their power, takes away their responsibility, makes them kind of servants of other forces within themselves. And just as a footnote, in psychotherapy, it is virtually never true that a patient cannot do something. It may be that it's difficult to do, it may be that it's arduous to do, maybe that they secretly don't want to do it, but it's virtually never true that they cannot do something. If you let a patient say, I can't, you basically have ended your therapy. So I challenge patients on that. I don't let them say, I can't. I push them to the mat, so to speak, to clarify that. And no therapy, no matter how wonderful, how amazing it is, can work unless you have a strong therapeutic alliance. I know this is obvious, but I just want to state that to be clear. So that's chair work. So now we're going to look here at schema therapy. So here, I'm understanding schema therapy as a parts therapy. And I think at this point, most schema therapists do see schema therapy as a parts therapy, but this has been an evolution of our model. So internal dialogues. We look at schemas, we look at modes, and here I collapse them into kind of the same group. We see they frequently take the forward perspectives on the self, some sort of self-definition, perspectives on the world. What is the nature of life? What is the nature of the world around us? Rules or injunctions about living. This is the best way to behave. This is a good way to live your life, or at least is a good way to survive, I might say. Or the importance of expressing a particular mode or part. Again, certain ways of behaving specifically in the world to survive. What we're doing here today is looking at how schemas and modes can be re-envisioned as parts. And if a schema is a part or a mode is a part, then we can treat them, they can see them as a form of internal relationship. And we can treat them as a dialogue, as if it's a dialogue between two people. And here I'm primarily drawing on the work of Iris Mardi Oliveira, but also Eckhard Roediger and colleagues, and the Stickens and the group in Belgium who came up with this idea first, as far as I could see. That we're looking at, it's not just a belief, but it is, a relationship. And some schemas, probably more in the primary schemas, but not only, can really be framed from a belief into an accusation, right? Schema is accusation. So looking at the YSQ, one of the items is, I'm fundamentally different from other people, but that now can be reframed as you are fundamentally different from other people, an accusation from an outside force. Or I'm a bad person that deserves to be punished can now be, you are a bad person. So when we're working with schemas, we're going to work with the evidentiary dialogues. And there are 3 steps to this. The first one is we want to interview the schema, put the schema in a chair, talk to the schema, and better understand it. This will be a giving voice kind of dialogue. Next, we want to look at their current experience and personal history and get a list. What's the evidence supporting the schema or the schema accusation? What's the evidence that opposes or is against the schema accusation? Right? And then we do a polarity dialogue between these 2 perspectives, right, to understand how true they are. And then using this as a foundation, we can create a dialogue between the patient and their schema, where this can get played out. And this work is here to explore the validity of the schema. Is the schema true, either in part or in whole, in the past, in the present, or it was never true, it was actually some sort of distortion? So adapting a case with a patient of Jeff Young's named Sherry, who's a psychiatric nurse, her defectiveness schema says, you are defective and you are unlovable. So to begin with, she would sit in the other chair. She'd be the defectiveness schema accuser. The therapist would sit in the chair. We'd have a conversation. Who are you? What are you all about? When did you come into Sherry's life? Why have you been sending her these messages? Why did you come to believe this? Right? So this is an exploratory dialogue here. It's not going to confront the schema, not going to challenge it. It wants to understand the schema, what its history is, what its function is, why it believes these things. Then we're going to make this list. What's the evidence for defectiveness? What's the evidence against effectiveness, right? She goes, no one ever loved me or cared for me as a child. That's one. But currently she goes, my husband and children love me and my patients like and respect me. So we have these 2, I'm unlovable, but actually I am loved. So we have 2 conflicting sources of evidence. Then she will do this dialogue here with the therapist where she puts, in the middle with healthy adult mode, 2 other chairs. One, yes, I am unlovable or defective. The evidence seems to support that. No, the evidence does not support that. Back and forth and back and forth. She'd make a decision. What does she believe about that? We can discuss with the therapist. So we have this kind of, the 4 of us in a sense can discuss this together. Having done that, we now go where she's going to dialogue with the schema itself. So here she's going to be both her healthy adult mode and the schema accuser. She's going to go back and forth between the 2, have a dialogue where she defends herself. The therapist also gets involved and challenges the schema. So, what you said was never true, or it was true when I was a child, but that's not true anymore. Or, yes, it's still some of that, maybe something I want to work on. But we're getting a lot of clarity here. So the schema is not automatic anymore. It's now outside of the self to some degree. She's able to see it. She has a relationship with it. This weakens the power of the schema, and she can live in defiance of it as well. So that's the schemas. Looking at the modes, we know that healthy adult mode has dialogues with many different modes. I'm just going to look at 2 of them today. Coping modes. So coping modes, as we know, are methods of survival, right? They come to help us stay alive, help us to function, especially in difficult situations. And we all need our modes, right? We can't survive without them. So the modes themselves, coping modes, are not a problem. When used excessively or inappropriately, they can become problematic. Coping modes often have origins in childhood adversity or trauma, and they also may be a response to recent trauma as well. Look at the compliance surrender coping mode. This is where there's a massive imbalance between the needs of the self and the needs of others, right? The patient is passive, submissive, self-deprecating, very dependent, reassurance-seeking. They allow themselves to be taken advantage of, allow themselves to be mistreated, right, or be abused. It's very much a kind of a victim state of survival. Avoiding coping mode, something we see more commonly, perhaps detached protector, really shutting down our feelings. In more extreme forms, dissociation or depersonalization, but it's to get away from feelings. And certainly self-soothing, self-stimulation, these are more of the addictive things, drugs and alcohol, other behaviors like that. Also, cutting is a self-soothing activity. Some people want to go down with their emotions, some people want to get more stimulated, but in both cases, it's an attempt to get away from the underlying pain. Angry protector, I think, is a more recent one, of kind of being angry all the time to keep people away. So here again, we're going to do giving voice. Ask the patient to move to another chair, and the therapist is going to interview the coping mode. Again, not challenging it, just exploring with it. What's this all about? So Sabine is a patient in therapy, and she has spoken about having a wall that protects her. So this is a dialogue. Therapist says, Sabine, you've been talking about the wall that protects you. If you're willing, I'd like you to move to this chair and let the wall speak. Sabine moves to the chair and she becomes the wall. And the wall says, since I came into Sabine's life, she finally has some peace and quiet. I hope to keep her safe. Therapist, why did you come into her life? This is the wall, basically. I first came into her life because her father would get aggressive and threaten her. I would shut everything down so that she could survive. Later on, her classmates were cruel to her, so I continued to shut things down. Therapist, sounds like you really helped us to survive. Sabine is the wall. I did. I adapted this from Arnson Jacobs' book. So here we see the wall as a protector, right? So the question will be, this work during these difficult situations, is this still the way you want to live your life now as an adult? But avoiding coping also can be more recent. So this is the story of Andrea. She said, I used to be this lively, happy girl ready to take on the world. I was so excited about college. I knew good things were ahead of me. And then she was gang raped. She says, but now I'm scared, lonely. I'm a scared, lonely, and ugly girl inside and out. I have no ambition. All I cared about is being left alone so I can be safe, right? So now we have a coping mode much later in life, which we want to work with as well. Overcompensating modes, self-aggrandizer, being entitled, grandiose, competitive, abusive. This is sort of the narcissistic spectrum. Bully and attack, threats, intimidation, aggression towards others, maybe a little more in the criminal justice system, but not only other people, bullying other people. I think more recent was the over-controller one, over-controlling others, suspicious, sort of paranoid, judgmental of other people, over-controlling of the self, self-harm, self-criticism. This would be some of the eating disorder issues. Right? But it's all too much, right? That's kind of again, in the right doses, these are all healthy, but they're too much here. So with patient, you want to do a cost-benefit analysis, right? Again, we affirm these were historically helpful. They wouldn't have them if they didn't help you survive. But what are the current costs and the current benefits? We want to do this work first, then we can have a Chairwork dialogue. And here what we're exploring is really the utility of the coping mode. The schemas, we looked at the validity, were they true? But the coping modes, are they useful? Right, so John's got a cocaine and alcohol problem. He's using to deal with his emotions. Just a couple of things. Coping with the benefits. I feel physical pleasure. It reduces my inner critic voice. Interesting to say that. Escape from bad feelings. An interesting one, he says, I feel like when I'm by myself, I'm too flat. But when I have some substances in me, I'm more kind of alive and I'm more real and people will know who I really am. Downside, I'm not as productive. That was certainly the case. My body hurts. I feel guilty. I'm really worried I'm ruining my health. Nicole with the bullying and attack mode. What's the benefits of being aggressive? Others respect me as they are afraid of me. And this one's interesting. I can make sure that no one will abuse and hurt me. And here you have a sense of the history, that something went wrong in the past. That something haunts her from the past, and she's saying it is not going to happen again. But there are costs here, right? Others are afraid of me. That's why they don't like me. So I'm lonely. I keep getting in trouble with the law, so I'm going to lose my freedom. So here's Nicole's cost and benefit dialogue. And this is what we call a rhombic dialogue. So we have 4 chairs here. So here Nicole is going to be her healthy adult mode. She's also going to be the bully and attack mode. And she's going to speak from the side on the benefits of what the bully and attack mode has been doing and the costs, right? So we're getting full exploration of this. And the basic idea is that we need a new relationship between the healthy adult mode and the bully and attack mode. We don't want to get rid of the bully and attack mode because this is the defense system of the patient. She needs this, she wants this, otherwise she'd be a complete victim. But it's too aggressive. It's in America we'd say it's like living on DEFCON 1 all the time, which is full scale alert of being attacked, right? And also believes that offense is the best defense, which is not going to work anymore. Also, the question is, does the bullying attack mode believe that Nicole, as the healthy adult mode, is strong enough to protect herself? And often these coping modes do not believe that. So that's something to be negotiated. We also might want to teach Nicole how to be more assertive, so she has other weapons than just being aggressive. So this is a very interesting way of working with patients. Very interesting to see this. Going to another set of modes. So this is the inner critic modes. These are a little bit different. In a kind of startling and really very disturbing quote, James and Catherine Elliott wrote, "Inside of each of us is a negative influence that is responsible for 99% of our psychological problems. That negative influence is the inner critic." Tammy Simon, the writer, did a radio show, and there were some major errors, technical errors in the radio show, and but it worked out. But she was so distressed that things had not gone perfectly. And then she had a major inner critic attack. She said, "I felt like I wanted to die. I crawled into my bed and I squeezed myself into a tight ball for about 24 hours. There was no comfort there. Only a terrible voice inside that said things like, 'You should kill yourself now.' I had a terribly mean voice inside that responded to difficult situations by punishing me and declaring that it would be useless for me to continue living. This voice spoke to me in a way that I could never imagine speaking to another person. Yet it lived in me and had the potential to turn on me if things didn't go well." And Tammy Simon actually created a book on the inner critic called The Self-Acceptance Project. We look at the masters, the great teachers, about the inner critic. We find that the masters do not agree. In a kind of a more traditional approach, we see that with Freud. We also see that in schema therapy. The idea is that the inner critic is basically an internalization of people in authority, parents, religious figures, teachers, maybe people who've hurt us, abused us, bullies. These are other people that live inside of us in some way that may be very unhelpful or even destructive. In more recent years, we are seeing an emergence of a view of the inner critic as fundamentally as a protector, actually inner critic as a coping mode itself. That it comes early on in the child's life to keep the child safe and help the child function. So this is a dilemma because we have two different kinds of inner critics. Schema therapy traditionally was the internalized abuser model. And I think that makes sense because Jeff is working with a lot of borderline patients. But actually, I believe, and I see that Rod Brockman and Winnie Bahari agree with me, that actually the protector critic is much more common. And that's really the one you're more likely to see. So it's very important you differentiate the diagnosis. On the other hand, in IFS, where they say, no bad parts, it's not actually true there are no bad parts. There are actually there could be a very lethal inner critic. And the transactional analysis people have great stories about these critics trying to kill the patient, right? So we really need to clarify both. But my sense in kind of a North American population, it's about 80-85% is going to be a protector critic, not an internalized abuser. But you do need to check it out. So again, another internal dialogue. So again, we move the patient to another chair. Can you be your inner critic? And I talk to the inner critic. And here you want to really explore what the inner critic is about, its history, its function, things like that. So here we can interview the critic, right? And we're doing giving voice. So basically we're trying to understand what's its origin, what's its purpose, When did it come into the patient's life? And often you will see there's a trauma story there with its origin story. One thing Leslie Greenberg has done, which I find to be very useful, is trying to get to the core value. So if we're looking at this as if they're two people, why do you care if they lose weight? Why do you care if they make more money? And I don't accept a socially acceptable answer. I want to know, why do you specifically care? I often say, there are plenty of people in this world who are overweight. There are plenty of people in this world who don't make a lot of money, or not successful. What difference does it make to you? And I really push that part to tell me why it cares. If it is a protector mode, you will get underlying fear and anxiety that will begin to emerge. You say, okay, but if it's an abuser, it will say something hateful, like, well, they're lazy, or they're fat, or they're a loser. You will get that kind of voice. And that's how you begin to know which kind of critic you're working with. Again, if it is a protector mode, like we saw before, yes, you've been useful. Yes, you have good intentions, but you're clearly missing the mark and you're causing problems. We see that again. So again, the core issue here is you want to change the balance of power between the healthy adult mode and the inner critic. More power for the healthy adult mode, less for the inner critic. And basically the idea, this is my life, it is not yours, I do not work for you. So if it is an internalized abuser, the patient's not going to play the role of the abuser, but I reject you, I say no, you want to get anger going, you do these chairs on the side. This is so much pain, this is how much suffering, this is how I've hurt so many years because of you tormenting me, and really speaking from the anguish, and then speaking from the rage. You've cost me so much. And you give this chance to really encourage the patient to express their rage as if somebody has hurt them, as if this is it is really an abuser. But it's my life, it's not your life. And also telling the patient, this voice is not on your side. This is not your friend. This voice is not trying to help you. This voice is, I would say, evil, which is a shock to patients because they've been listening to this voice for a long time. Nobody's ever challenged that voice before. So this is a journey because it's been there over and over again, and these voices don't necessarily give up easily. But labeling it's not friendly, it's abusive for whatever reason, and we get to say no to it. If it's a protector, then we can go, gratitude, thank you for what you've done. This is how you're causing problems in my life. And the patient can be both themselves, and they also can be the protector and a critic. So one thing is the inner critic says, I don't think the patient, again, we see the same things before, is strong enough to stand up by themselves, right? We have to have that renegotiation of the relationship to make the protector critic an ally. Another thing is that we want to do a values clarification. Often these critics have strong values, but is a healthy adult mode? Does the patient want these values? Maybe yes, maybe no, maybe not to the same degree. So this is a whole negotiation here between the healthy adult mode and the protector inner critic. So in reality, these are much easier when you actually do them and explain them to you. But I think you get a sense of them. But again, it's this interesting relationship dynamic between the parts. So I've been working on the internal world of schema therapy, but we obviously are not just an internal psychotherapy because all of this is often about mistreatment. So there's an interpersonal world as well. And using two of our ideas that we use with trauma, I think are very useful here. The first one is storytelling. So we do what we call trauma-centered storytelling, or really repetitive trauma-centered storytelling. And storytelling in our mind is really memory telling. That is, we don't want a story about my life in third grade. We want specific memories. We often ask people, are you haunted by a memory of something that happened to you? So we first began doing this. I would invite patients to move to another chair, and it's a patient with a trauma history and a trauma they want to work through. Move to another chair, and in this case, say the patient's name was John, it was a car accident, and I invite him to tell the story of his car accident. So he goes into another chair, he goes, I was in a car accident, and these are some of the things that happened to me, and he tells the story of his car accident. I then invite him to stand up, move around, shake it off, sit down, and tell the story again. When he does that, I again stand up, move around, shake it off, sit down, tell the story again. Get up, move around, shake it off, sit down, tell the story again. Get up, move around, shake it off, sit down, tell the story again. Get up, move around, shake it off, sit down, tell the story again. 3 to 5 times. Right? So as you can imagine, this is a very emotionally grueling experience, very emotionally intense experience. But it's also very healing. Because what happens is that as they go through this, more details begin to emerge. And as more details emerge, it means that integration is taking place. And often if you go through all 5 things, you see kind of a peak of emotional intensity, and they kind of begin to really organize themselves by the 4th or 5th time. So this was a very powerful way of working with patients. It was very successful, but difficult. In 2018, I discovered the work of Roediger and colleagues, where they suggested doing third-person storytelling. So now we would say to the patient, go to another chair, say to John, so John, don't tell me what happened to you, but tell me a story about John, or a man named John who was in a car accident. So he would say, John was in a car accident, and these are some of the things that happened to him. And he would tell the story. Again, we tell the story, get up, move around. We do this 3 or 5 times. This was a real breakthrough for us, because trauma, as you probably know, is very complicated. People feel, even if they're the victims of the trauma, they feel shame, they feel guilt, they feel embarrassment. This way of storytelling gives more space between the person and the story, but it allows for enough emotional activation to be therapeutically effective. So this is a great way to do this, and this is what we usually do. Second person storytelling, interestingly enough, is a more advanced form of storytelling. Here we have 2 chairs. John would sit in one chair, he would imagine himself in the chair opposite, and he would tell himself what he went through. John, you were in a car accident, and these are some of the things that happened to you. Right? He would tell himself what he went through. He could then switch chairs, become himself, and respond back, be the part that was in the accident, respond back to what he heard, then go back and forth. What's really nice about this is it really opens the door for compassion and kindness and caring from yourself to yourself, really to your younger self that went through the trauma. But many patients are not capable of compassion for themselves. So this is a more advanced form of chair work. So I would do this down the road. Basically, however, you can just do third-person storytelling and you'll be fine. But you can do the other if you like. Now, again, some people, very difficult to do this work, right? They're not going to do 5 times. But so we do it 1 time, or we do half of it. We do 1 sentence. We start there. We're in the school of thought that exposure leads to integration. So not everybody believes that, but we believe that. So this is why we think it's important for them to find a way to tell these stories. And to that end, we think third-person storytelling is great. We've also had the experience of patients come to see us and they've been traumatized and they've been in therapy before. And we say, did you talk about this when you were in therapy before? And they say, my therapist and I talked about this once and we never returned to it again. So what do we make of this? Well, the therapists don't want to hear trauma stories. These stories are disturbing. They get us upset. We like the patient, right? They may be triggering for us as well. If you do this model of repetitive storytelling, not only does the patient begin to integrate the trauma, but you begin to habituate to the trauma. So once you've decided you're going to do this, you're going on this journey, you begin to relax, you'll be able to breathe more slowly, you get more freedom to actually ask the patient about with the specifics of what happened. So I think everybody gains here from this approach. So that's storytelling. In relationships and encounters, right? Confrontation dialogues. You're sitting in one chair, looking at the people who hurt you in some way in the chair opposite. You express anger, fear, distress, and or sorrow. So here we can use many chairs. So here the patient we can speak with, we can nurture the abused child, confront the abuser. We actually can confront people who knew the child was being abused but did not protect the child, right? And some people are most angry at people who did not protect them, even more so than the people who hurt them. And here both the patient and the therapist can speak to the person in the other chair. And I think it's very important that the therapist speak to the child. Many patients have no compassion for their own child self. But here the therapist, can speak and be affirming and caring. One model I like to say with the abused child is to say, I see you, I know what you have gone through, or I know because the patient told me what you went through, and I feel distressed about your suffering. Which is always the heart of compassion. I know about your pain, I feel distressed about your pain. I would not tell the child if things are going to get better because child will never believe you. But this, I think, is a good model. And the patient also hears that, which is healing for the patient. To hear you talk to the child self that way. It's kind of a form of reparenting. Confronting the wrongdoer. This is from the work of the Gouldings and their amazing model. They suggest this kind of 4 steps here. This is what you did to me. So what are the specifics of what took place between the person and the perpetrator, or the person and the abuser, right? Telling the story of the specifics. This is how my life was immediately changed because of what you did. I felt tainted. I felt terrified. I felt the burden of a secret, whatever it was. This is how I've lived my life because of what you did. I've been chronically depressed. I've been cutting. I've been getting high all the time. I've been promiscuous. I don't trust anybody. And then this is not in one session, but at some point, they make a redecision. I'm now rejecting the pain and damage that you inflicted, and this is how I'm going to live. Basically, they give up the coping mode or the extreme coping mode. They claim their life. They claim their authority. I'm not going to be a victim. You're not going to haunt me anymore. So the goal here is to challenge the pathogenic internalization of the trauma. So here again, we do not do role reversal with the abuser. I do role reversal with the child, but not with the abuser. And why is that? When you do role reversal and play the other person, you normally get empathy for whoever you embody. Jeff Young made, I think, a very brilliant point when he said, when something goes wrong in childhood, an early maladaptive schema is formed. And the way to heal that schema is through anger. Right? And he points to the point of anger as a core force in healing trauma. I think he's right. I also think actually grief, sadness may be the ultimate part of that journey, but certainly anger is important. If you play the role of somebody who hurt you, if you embody them, it's much more difficult to be angry. So we never have the person play the abuser. Literature is mixed on this, but we don't do it. So again, adapting a case from Jeff Young and colleagues, just to show how this plays out. It's kind of an integrated case. So Ivy has a self-sacrifice schema. She puts the needs of others before her own in a way that's very problematic. And this is causing her to feel frustrated and depressed. She has a friend named Adam. She spends a lot of time with him. They always seem to be focusing on his life and his challenges. He asks her, he's not a narcissist. He says, what's going on with you? But she feels unable to really share her life with him. She feels blocked. And she feels depressed and frustrated about this relationship because she feels she never kind of comes into the conversation. So here she is, a self-sacrifice schema is preventing her from sharing her concerns and her issues. So then with the therapist, she does a dialogue between the schema side, which is self-sacrifice schema, says, his needs are more important than yours. You should take care of him. And the healthy side, which says relationships are based on balance and reciprocity. I listen to his needs. He listens to my needs. There should be a fair balance. So with Chairwork, we could put this into a chair, evidentiary dialogue here, clarity dialogue, speak from the schema side and from the balanced relationship side. In this case, when Jeff Young did this work, she began to get angry at the schema. And then he said, close your eyes and bring up an image. She wrote an image of taking care of her mother. And then she confronted her mother in the image saying, it cost me too much to take care of you. It cost me my sense of self. And here we can do this with chairs as well. The patient can now imagine the mother in the chair. It cost me too much to take care of you. It cost me my sense of self. So here, chair work and imagery work can be intertwined in many ways. They're both very powerful. I think chair work is a little bit less lonely because you're kind of there with the therapist. And some people, in my opinion, my experience, who are abused do not want to close their eyes around other people. But it's your choice, but it's just an interesting way to try things and do both. Lastly, negotiating the therapeutic ruptures. We work with personality disorders. We work with difficult axis 1 disorders. And this is what we do as schema therapists. And when we're working with patients that are this difficult or therapeutic situations that are this difficult, that we can get stalled out or into a negative experience. So here we can both stand up side by side. We can look at what's going on below and discuss it. Each person say, what's going on with the patient? What's going on with the therapist, right? And this is great. This is the work of Roediger again and colleagues. He wrote, talking in third-person language and looking down on the chairs together makes reconnection much easier. It's a way, he says, to lower the emotional intensity, move more into healthy adult mode, and discuss what's going on. So this is a great thing to keep up your sleeve if you're having trouble with a patient. So how does Chairwork heal? I don't think we really know how Chairwork heals, but a couple of ideas. So one, it brings clarity to the parts, which leads to greater control over them, right? So we put parts in chairs. We put parts in chairs so they're outside of us. We can look at them. We have much better understanding what's going on. So how does Chairwork heal? I don't think we really know, but some thoughts. So one, it brings greater clarity to the parts, which leads to greater control over them. All right, so we're putting them in chairs outside of ourselves. We're getting them to speak. We can look at them. We can see them. So we label them. So all of this gives us greater clarity. So we're aware of the part when it gets activated inside of us. It facilitates encounters and dialogues that might, among the parts that might not naturally occur. We don't normally do this with ourselves, talk to these parts. Sometimes we do, but often we don't, right? So we can, thinking like you say, should I have a vacation in Florida? I have a vacation in California. On Monday, I want to go to Florida. On Tuesday, I want to go to California. I can actually put the two together and have Florida and California talk to each other, and I can make a decision. Right? But we're not overtaken by a part or a mode so much as we were before. It promotes high levels of affect and emotional expression, which facilitate cognitive restructuring and the resolution of traumatic experiences. Dr. Marvin Goldfried and Dr. Jeffrey Young both believed that you needed high levels of affect for cognitive restructuring to be effective. So that's in the CBT world. In the trauma world, while there are different feelings about this, there is a school of thought that believes higher levels of affect lead to traumatic resolution, which we are in that school of thought as well. And lastly, it can trigger creative processes within the individual that can lead to new life solutions. And this is definitely Fritz Perls, did many things with different parts, engaging with each other, encountering each other, listening to each other, and often a third force or a third part would emerge, some sort of solution. So I always like to thank the masters, Dr. Moreno, Dr. Perls, and Zerka Moreno for the incredible gift of chair work. And to close with a quote, psychotherapy is a sacred encounter between two people and is based in love and the skillful use of the therapeutic arts. The goals of the work are personal healing and personal liberation. And just for a couple of things, I've written a book on Chairwork, Transformational Chairwork, which you can get on Amazon. And more recently, my colleague, Amanda Garcia Torres, and I have written a chapter in this book on experiential therapies for treating trauma. We feel very fortunate to be part of this book. We think this will become a classic in this area. And you can get this at Routledge. And contact information, Chairwork Psychotherapy Initiative is our training company. The Transformational Chairwork Psychotherapy Project is my practice. And here are some ways that you can reach out to us. So thank you for your attention. I hope you find this to be useful in your work as schema therapists.